Well, thank you for the opportunity to speak to you all today. I am a little disappointed at the weather. I've been blamed coming from Portland, Oregon, that I brought the clouds with me. We were looking for a little bit of sunshine, but hopefully it'll clear up tomorrow after the meeting's open and some of you can enjoy some sun. So my charge today is to talk to you a little bit more about basic CBCT use in clinical practice. We're going to hit a variety of different areas. And what's surprising to me is when I give a lecture, it doesn't matter where it is in the United States, a large percentage of the group I'm talking to that place dental implants surgically do not take advantage of CBCT technology. And so for that reason, I'd like to today take a step back. We've seen some outstanding presentations where you see a lot of CBCT used for both research as well as to document cases. But to show you how I use it in my private practice kind of on a day-to-day basis so you get a little better understanding of what I'm using for my decision-making trees. So we're going to talk a little bit about the CBCT background. Then we'll talk about immediate implants because I do think there is a great indication for immediate implants. Today we've heard Danny Boozer give very nice rationale for delayed. I know Dennis Tarnow is going to talk this afternoon about just the opposite, the advantages of immediate. And the reality is those of us in private practice are kind of fighting both ends of that spectrum. We have patients where we can get away with a delayed placement, but then we also have those that want everything yesterday and have high demands and have to push the envelope for that. Then we'll chat about bone graft surgeries, how we use it for both the pre-treatment planning, but also then for the assessment of how successful we are with these new bone graft materials. Danny showed it nicely. He showed 100 different bone grafts on there. And so what you need to do is you need to carefully evaluate what you are doing on a day-to-day basis, your hands, your materials. And the only way you can be effective is if you are looking at a CBCT data point. Two-dimensional radiographs can look fantastic. You look at the 3D image and your results could be pretty mediocre. And so different bone graft materials need to be evaluated in your hands and have a nice little regime that you use on a day-to-day basis that can give you predictable results. Finally, at the end, we're going to talk briefly about guided surgery and the digital process. I just want to share a little bit of what we're doing with in-office printers to make our own surgical guides. It's been kind of exciting, a little area that we've been working with. So if you're interested a little bit more on the scientific side of it, as far as the dosing of the different units, this is a great article that we wrote that gives a little bit of the scientific side to it. Obviously, today we're going to be very limited in that. But this article really kind of gives the rationale again for the CBCT and talks about the radiation exposure, the ALAR technique, and that's part of what we're going to talk about today, but in a very abbreviated fashion. So this is a paper by my good friend Mike Sonic. This is 1994. And in 1994, we already knew that we needed CT scans. This is part of why the industry has been driven, is the percent distortion on two-dimensional radiographs. That still exists today, yet people continually will use a two-dimensional radiograph with distortion to treatment plan their implants, and then they get into trouble. We have this beautiful technology. We should utilize it when it's indicated. So rather than have 14%, 23%, you can get down to under 2% as far as your distortion, which means you can be very accurate in your placement, and we can push the limit much more than we can with two-dimensional radiographs. Now, historically, one of the things that's limited the use of CT scanners is the medical multi-slice CT scan machines. These had high expense and they had high radiation exposure. They could be upwards of 100 times what the CBCT will be today. These units today can be down as low as 5 microsieverts. That's 2 days in the sun. That's one flight to get to this meeting. So most people will not have any negative impact whatsoever by utilizing the CBCT, and they can have a huge improvement in their outcomes. And that's what we have found. And again, as was discussed earlier, there are so many aspects of our treatment that we can optimize by understanding what's happened in 3 dimensions. So the adoption of CBCT technology has been quite profound. Very few things in dentistry with this kind of price tag show this kind of exponential growth. The problem is there's still a tremendous number of the implants being placed today in key anatomic areas or in aesthetic zones where the CBCT is not being utilized for preoperative planning, nor is it being utilized to evaluate your postoperative results. As Danny mentioned earlier, 5% of those cases will not have a buccal plate, even when done by an excellent clinician and using excellent graft materials. And what that means is we'd like to know which patients they are so that we can plan accordingly and make sure that we're monitoring those patients carefully, and we can give them options as far as supplemental grafting. And ultimately, there are some cases where it's the true placement. I've removed a tremendous number of implants. Obviously, the ones that he showed, they did have a slight error in the placement, and that's why they resulted in lack of buccal plate. But on a daily basis, we're seeing cases come into our office where these implants are placed completely out of the bony envelope, no regard to the 3 dimensions. So the evolution in my office has been our early CT scanner. I was the first in Oregon to get a CT scanner, and this was in, I think it was 2007, 2008. And we could see quite a bit with that scanner, but they've improved tremendously. More recently, I have a CS9300. We got that 4 or 5 years ago, and you can see with the CBCT image on the right, you can see things that you couldn't see with the initial ones. You can see how thick that buccal plate is around an implant. You can see how thick the buccal plate is around natural teeth. And that makes a big difference. The newest generation, the CS8100, we just got for our second office, and it has even more resolution, smaller footprint, and very, very small amount of radiation. These all have the multifunctional use in that not only can you use it for 3-dimensional analysis, but you can take a panoramic image. One of the advantages is that if you're just doing a screening, it's a very low radiation dose, and it can give you a lot of information for a large field of view. Now, the ALARA technique, as little as reasonably achievable, basically states that if you're taking a CBCT, you want to have a rationale. Every one of our chart entries, we say CBCT taken to show, and we list what it is that we're trying to figure out, and then we list what it is that that CBCT showed us. That way we can rationalize it, much like we do with any other periapical film, full mouth series, panoramic series that we've done historically. But when we're dealing with very small doses, the amount of potential damage to the patient, I think, is very low, especially with adults. With children, it is different, and we're much more conscientious in our patients under 21 years old. So we feel it's a negligible risk, especially when taking into account that you're dealing with up to 3,000 microsieverts per year. And if you look at this table, I don't want you to look at the entire table, but just at a couple of the figures, and you can see that the smaller field of view can be down in the 18 microsieverts. Again, very low dose, a couple of days of background exposure. So do understand with your CBCT unit what the dosing will be, what the impact is, educate your patients, and then take advantage of it. The workflow is much easier in your office. You're going to have an accurate treatment plan. You can treatment plan it at the consultation if you have it in office rather than sending it out. Again, lower radiation than a hospital scanner, lower cost to the patient. We now have focused field of views, which is very nice so that you don't have to read the entire scope of the patient's arch if you're doing a single unit. And it really helps us to engage the patient, which equals higher case presentation acceptance. And then team communication. This is especially critical with surgical guides. So we can take these 3D renderings and we can show patients where the nerve exits. We can show them how narrow the ridge is. And you can really demonstrate exactly what the challenges are, and with these challenges, how you're going to solve it for the patient. Ridge width issues. The regular radiograph doesn't show this, but then they can clearly see when you show them this image that there's only 1.9 millimeters. And when you're going to place an implant that's 3.3, they immediately understand the challenges. Now, I've found that a lot of times we'll show them a defect, say you have a resorption defect, and this is where we're placing the implant. When it's the 2-dimensional black and white views, they don't get it. Somehow with 3D renderings, these are the most useless for us. We look at the 2-dimensional images for our primary use at the different, axial plane or sagittal. But somehow this 3-dimensional rendering is what triggers the patient to really understand, hey, that's me, this is the defect I have. And so it really helps you in getting these patients on board with the treatment and explaining to them why you can or can't do what they want. So with case planning, there's a variety of anatomy. We're all very familiar with them. One of the key things that was discussed today is the buccal plate thickness. I think that that's something that I want to know exactly what's going on for any immediate implant that I'm doing. We need to know if that buccal plate is intact or not. We need to know the anatomy. And that will help us make decisions with the graft material. If we have a limited buccal plate, we're going to want a material that stays around longer. The xenograft, as was shown with that histology, it will be there for a while. It helps you with the dimensional stability. Maybe a case you need to do a contour graft. If instead you have a very thick buccal plate and all you're doing is filling a fairly small horizontal defect, then maybe you can get by with just a typical allograft. Mineralized allograft can be very effective as well. So it helps me decide which of those I'm going to use. Now, if I have a much bigger defect, say I've got 2, 3, 4 teeth, horizontal, vertical defects like we'll show later, that's when I'm looking at a much higher performing bone graft material, either autogenous bone, or in our hands, we found that the cellular allografts can perform as well as autogenous bone, and we're having great success for very large augmentation cases utilizing the cellular allografts. Flap design is another aspect that the CT scan can give you a great understanding of how you're going to tackle that case. Whenever possible, we of course would like to do a flapless approach, but we also understand that if you leave too little bone behind, you're going to wind up with recession and long-term stability issues. So here's a case where the CBCT gave us a lot more information than this two-dimensional radiograph. The two-dimensional radiograph suggests that it's a relatively straightforward immediate implant. You look at the CBCT and we've got a very large periapical pathology, and we can see that that's going to pose a little bit of a challenge degranulating that defect. With almost a complete loss of the buccal bone, we decided that this would be a case that would be easier to clean this out flapping it. It is also feasible to try to tunnel or to use a semilunar incision down at the periapical region, which I have done, but sometimes in these very large defects, I find it difficult to clean that defect out thoroughly, and therefore I feel I still have a better result if I go ahead and flap it to clean that out. Now, I'm using an incision design that is sparing these papilla because that's the most difficult, is to try to preserve those papilla for maximal aesthetic outcomes. So we use our bone graft material. Here we need space maintenance, so we went ahead and used a xenograft with a collagen membrane and an immediate provisional. And you can see the healing is within normal limits at 1 week, even in those incision design areas. And you can see our CBCT to analyze what we've accomplished, make sure that we've stayed away from all of the key anatomy, and we can make sure that we've got what appears to be excellent buccal bone, because this bone level is critical if we're going to move on to the restorative phase. So we'll go ahead and we will measure that and make sure we have that 2 millimeters prior to sending them off for restoration. There are going to be a few cases where you don't get that, but if it's only 1 in 20, I think moving forward with an immediate is a reasonable outcome, especially in patients that are going to be those that are very demanding. So if there's insufficient buccal bone, then you have to make decisions. Do you go back in, do supplemental grafting? Do you discuss it with the patient? We've done it both ways. We've let the patient make that decision. But if you've not taken the CT scan, your two-dimensional film is not going to give you that information. So I think if you look at the side views, you'll clearly see that we have very little scarring and we've got an excellent outcome. There was a slight amount of composite that was added due to the shape of this tooth. Tooth number 8 was definitely triangular in shape, which, as we know, looking at the aesthetic risk profile, makes a big difference. So we had discussed that prior to with the patient because that was anticipated. But even with these kinds of incisions, we can still get a very aesthetic result with a very predictable outcome. This is, the patient came back for another need, and we went ahead and took a CT scan. This is about 4 or 5 years later, and we're still seeing fairly good dimensional stability in a case where we had a very tight dimension, as you can see. So here's a challenging case. Is this an immediate implant case? Probably most people would say no. What about if the patient sort of gave that, I've got a wedding, I've got to go to, it's in 3 months, and I can't look like this. Obviously, you're not going to be able to stage it and go through that. She wanted to finish everything. So we said, well, there's risks associated with it. We outlined the risks, and she was on board with that, so we went ahead and initiated it because we did have excellent bone at the apical region per the CT scan. So we inverted that bone that was present, did soft tissue grafting, bone grafting with a xenograft and a provisional, and this is what it looked like at 3 months when we sent her off to have everything restored. And you can see that we had a nice amount of buccal bone, so we did feel comfortable moving forward. Is this a normal case? No. This was a case that was treatment planned to do a staged approach, but the patient had certain demands. And the unfortunate situation these days is that a patient who wants things yesterday will go and find somebody that will do it. And so what's important is if you've educated them properly and you've given them the pluses and the minuses to let them make that decision. If you do this procedure on a regular basis, we do almost every case of ours as an immediate, at least in the anterior maxilla, and as often as we can in other areas. We've just found it so demanding that the patients are asking for this. If I could do it as a staged approach, I think that obviously that would be the best, and we review that with the patients. Ironically, even when faced with risk, the patients usually make that decision. Now, the problem is you have to look at what your own individual outcomes are. In other words, I've been monitoring my results with CT scanners and making sure that I do have that buccal bone and that I do have good long-term stability. If you don't routinely do immediate implants, the best solution is do a delayed. If you're going to push the envelope doing immediate implants, you must evaluate your results, not just two-dimensionally, but three-dimensionally. So Miyamoto's paper in 2011 was on immediate implants, and they very clearly showed more recession with immediates when there was less than 2 millimeters of bone remaining. So I think it's pretty clear from prior speakers and the future speakers at this meeting that we know we would like to see that 2 millimeters of bone. That's going to be critical for the success. Is it just the bone? No, it's also the soft tissues that are important. One way of doing the thickening is described by Danny Boozer. You can go ahead and do a delayed approach, and what fills in that socket can increase that volume of tissue and avoid soft tissue grafting. Well, one of the things that we'll do is preoperatively we'll take a scan, intraoral scan, mate it to the DICOM data, and that will allow us to visualize what kind of soft tissue thickness we have. You can also use it to evaluate on your actual implants to see if, in fact, your soft tissue thickness is reasonable to help support that long-term stability. Another study using immediate implants, the Yoshino study that was in 2014, showed a significant increase in the recession when soft tissue grafting was not utilized. So I think, again, you have to have case selection. We do not utilize soft tissue grafts in every case, but when we are concerned about the biotype high smile line, we will do that. This is one of my cases where there was some slight recession on a failed tooth, immediate provisional with a connective tissue graft, and you can see an excellent outcome, and this also had good bone. So I think it's important to have both good soft tissues as well as good bone. We utilize the CBCT for immediates when we're doing full arch cases. This allows us to be very specific in our placement, avoiding the sinus, being right at the floor of the nose, maximizing all of the available bone, and giving us a nice outcome. Now, sometimes the CT scan will show us that clearly an immediate isn't indicated, or that it's going to be extremely challenging, and that we're going to do a delayed approach. Here, the stability just isn't going to happen, so we're going to need to do that in a staged approach. This is a case where we took an intraoperative CT scan on an immediate, and so you can see that we're getting close. As was shown earlier this morning, with the appropriate burrs, we can start pushing the limits. We've now got the imaging, we've got the burrs, you can also use the piezo, and what that allows you to do is encroach a little closer on the nerve than you might have otherwise. Normally, when you have this small amount of bone to engage for immediate, it's very difficult. This particular case, the assistant of one of our major referrals. So she's used to seeing immediates. She understands the risk. We discuss it, and she wants an immediate. Luckily, no paresthesia, no issues. But we're obviously closer than we would like to be. But again, the technology is allowing us to push things just a little bit with good burrs and, again, with the potential for intraoperative CBCTs. Now, it seems that every time I haven't done a CT scan where I felt, oh, I don't really need it on this one, that's when we can get in trouble. This is a case that I did, and it looked great two-dimensionally, and looks good at this particular location. But when you look at the axial slices, at the most coronal, it's okay, but you can see that we violated the canal in the mid portion of that implant. Even when I was palpating, I did not notice that. And that can happen. Part of it is the expansion that happens when the implant goes into your preparation site. Now, we see that there are a lot of cases where this can be even more substantial. This was a case from sort of pre-CT scan routine era. This is slightly visible on the two-dimensional, but this was back in 1999. And it looked great at the most apical standpoint. The implant was doing great still today. Patient came in for another problem, and you can see that they'd had a cyst there that had gone undiagnosed. Now, granted, this is 1999. This would not happen today in my practice. So it's imperative that you take a look at these CT scans, make sure that you do this type of thing preoperative before you go in trying to do your surgery. That way everybody's on the same page. So I think it's pretty clear that the bottom line is that we get better clinical outcomes with CBCT evaluated, restorative driven implant treatment planning. It isn't just restorative treatment driven because there are three-dimensional limitations within the bony topography, and so we have to have those plans in place prior to the start of your procedure. Now, one of the areas that I've been looking at quite a bit lately is the facial bone, lack thereof, on natural teeth. If you look at this CT scan, this is one where we were going to do implants in 7 and 10, and when we saw how thin this plate is, we do not want to do any kind of expansion with this orthodontic. So we put a palatal implant in, and then now we're going to open this space up for 7 and 10, and you can see our final implants show excellent bone volume that's present there. So it changed our treatment plan. Many of the orthodontists are not utilizing this three-dimensional technology. We're trying to get them on board, but many of them don't, and that can severely impact your outcomes. This is an article, I believe, is out of Boozer's group, but showed that about 85% show less than 1 millimeter in the anterior maxilla, looking at CT scans. So what that means is there's a lot of teeth out there that are going to have 0 to no buccal plate. This impacts your implant placement if you're going to lose the tooth, and it also impacts your soft tissue grafting if you're going to be doing connective tissue grafting. So this is a paper by McGuire and Shire, and this paper from, I believe it is about 7 years ago, clearly shows the potential is there to regenerate the entire attachment apparatus. So there's more and more emphasis and push trying to do that. So here's a case. This is actually post-adult ortho, and you can see quite a bit of recession, no buccal plate. So we're going to try to kill two birds with one stone, both graft for the implant and go ahead and graft on that root. We went ahead and took localized autogenous chips, just scraped and from the osteotomy, and we use enamel matrix derivative on the root and a connective tissue graft plus a membrane. So we're kind of utilizing everything to optimize this result. So the EMD is placed, bone graft is placed, along with the membrane and the connective tissue graft. And you can see at early healing, things are looking much better with regards to that dehiscence, good bone around the implant, and we're showing bone around that tooth root. And this is the final result. We've improved the bone on that tooth. We no longer have the excessive recession, and we have an excellent outcome on that implant. And so I think it's important that we look at these facial plate defects and we really try to regenerate the entire attachment apparatus as much as possible, not just do a connective tissue graft. Here's a very similar case. And you can see the CBCT shows that really our whole issue is that we've got a very, very thin alveolus. This patient was discussed ortho as one of the best options kind of to treat this whole scenario. But clearly some bone grafting is going to be needing to be done to help with this canine. And so a very similar protocol was utilized. And so we treat the root, did our bone graft, soft tissue graft, and our membrane. And then we utilize that healing abutment to bury everything. That just kind of helps hike the tissues up. And so you can see at 4 months, we've been able to correct that defect, and we have an excellent scenario to go ahead and restore that implant. Our CBCT evaluation is done to make sure that we've got good bone on that implant before we send them out. And we're also able to evaluate that, yes, we've improved the bony situation. Do we know if this is a complete new attachment? We don't know, but we certainly know you don't get it with just a connective tissue graft. So I think we're seeing that whole shift towards trying to optimize that regeneration. We see it for full arch cases. So I think that it is imperative that when we're doing soft tissue grafting, that you think through what that bony plate looks like, and that can help you make decisions as to whether or not you need to utilize bone grafting in addition to soft tissue grafting. And if so, what materials? One of the things that we're doing on some of these tougher cases where there is a lot of bone loss is we're utilizing cellular allografts. There's some great animal work to support that you can regenerate a complete periodontium through the use of the stem cells. So with staged bone grafting cases, clearly we utilize it for the planning. It helps us decide what bone graft materials we're going to utilize. Like I said, in the larger cases, we're using the cellular allografts. And then it also is utilized for the post-operative evaluation so that we can plan our implants. This shows a titanium mesh case utilized to treat this very challenging defect. We've got both a horizontal defect as well as a vertical defect. And by taking the CBCT, you can confirm that the placement of your screws is not damaging any roots or any positions that you wouldn't like. You can also perform a CT scan at the very end to make sure that indeed you have regenerated the amount of bone that you need to actually place your implants at the time of mesh removal. Otherwise, you have to plan for either shorter implants or have a backup plan, and it's best to have that all decided before you initiate your surgical treatment. So this shows the implants being placed on that case. We went ahead and we did a contour graft on this region because of the narrow nature at this region. The mesh, as it comes into that natural tooth, was a little limited in the dimension and the horizontal aspect. We originally had treatment plan extraction of that posterior molar, and that would have given us a little better contours. Unfortunately, the patient decided they did not want to take that tooth out, so our planning wasn't quite where we would have liked that had we known that was ultimately going to be our situation. These are a few cases that I've inherited where the post-operative CT scans have shown us very interesting findings. This mound is great volume of bone, but from a three-dimensional standpoint, there certainly is not going to be a lot of stability. So I think with most of our sinuses, we really need a preoperative and we need a post-operative CT scan so that we can evaluate for pathology and evaluate that you've been very effective with your bone grafting. This is another one. This particular one came from ENT because she was having issues that they thought were sinus, and in fact, it was just a mobile implant, and it was a dental origin, but when you take the CT scan, it's pretty clear that nobody had taken a CT scan to evaluate the poor bone grafting that had been performed. That sinus lift obviously had not been done properly, and that's something that could have been picked up prior to placing the implants. We also preoperatively see things such as vessels, and that can impact our lateral wall position, and we see septa. As you know, septa can really challenge your reflection of that Schneiderian membrane, and that can make a difference between if you've only done a few sinus lifts, if it's something you want somebody else to do, or if it's something you want to tackle. It certainly increases the complexity of the case, and it's something that you would like to know before you initiate treatment. This is a case that looked like I might be able to do an immediate implant. I've had them where I can basically utilize the socket and even just kind of engage the floor of the sinus. And so I was thinking of immediate implant, taking a CT scan, clearly outlined that that was not a reasonable approach. And you can see that the sinus was overlapping considerably, even though the two-dimensional film really only gave a partial indication. So we went ahead and we did a small sinus graft right through the socket, grafted this area, and we were able to get plenty of bone height and volume. It was a very conservative, again, just right through the actual socket itself. So to close things out, what I'd like to do is talk a little bit about guided surgery. Guided surgery has a variety of advantages. Clearly, it improves the surgical and restorative communication. That's probably the best utilization of this, because then the person restoring can look at what is hopefully going to be the outcome, and then you guys discuss together what the limitations are going to be. You can also involve the laboratory because there are certain issues in regards to interocclusal space. We know if you're doing full arch restorations, you need to have adequate interarch space. All of these are things that can be vetted out with good preoperative planning utilizing guided surgery. And it's best to, again, address these all before surgery, and that way you can make it a very predictable treatment plan. You can minimize your chair time and minimize the invasiveness. Now, one of the things that I've found is that while I would love to do things flapless, most cases come with inadequate bone and inadequate soft tissue. So what that means is I don't get to do as many flapless cases as I would like to do. But when they come along, we'll go ahead and utilize that technology. We also now have the potential to fabricate provisionals before the surgery because our positioning of these implants is going to be so precise that we can make the provisional, and then all we have to do is some very minor adjustments to the provisionals, and that's helped our chair time tremendously because of the length that usually happens when we have to do a provisional. So we have tooth-supported guides, relatively straightforward case, but with adjacent implants, it's really easy. They're like magnets. The two implants start coming closer and closer together. And so I think guided surgery can really always help whenever you have adjacent implants. The treatment planning, again, allows everybody on the team to understand what the limitations are. When you have poor quality bone or we're utilizing sinus grafting, that's when we start looking at the length of the implant and discussing diameters and numbers and splinting. Those types of discussions can all be vetted beforehand. Tissue-supported guides can work out great if you do not have to remove bone. That's the key thing here. If there's inadequate interarch space, the tissue, obviously, supported guides do not do justice. This is a case where there was adequate interarch space, so we were able to accomplish that. Placing our implants took less than an hour, very little trauma at all to the patient, and it was one of those situations where we did have enough bone and we did have enough soft tissue and we didn't have to reduce the interarch bone. Again, we don't see that on a regular basis. Most of the time there are adjustments made. So in-office 3D printers for guided implant surgery. This has been something we've been working in our office the last 2 years. Dr. Thomas Ashragi, my business partner, has been real instrumental in this. He's very much into the technology side of things. So we have 2 different 3D printers in our office. This is our newest one. It's a photopolymer printer. And we also have a MakerBot that was utilizing the heat extrusion mechanism. This gives a little better, higher resolution. But what it allows us to do is we can kind of take care of every step of this then in the office, from the planning to the ultimate printing, which I think if you look into the future with the way digital dentistry is moving, there's more and more trend to doing things in office. While we like to utilize the assistance of our laboratory technicians, there are certain steps that can be expedited. One of the challenges that I have found in the guided surgery arena is that some of these tougher cases, you're waiting 3-4 weeks to get your guided surgery case completed when you're utilizing some of the labs. And this is something that really, if you need it, the patient wants to do it tomorrow, you can stay up late and you can take care of this all within your own office. So a couple of the neat things that we've been able to develop is the technology to remove teeth. If you look at most of your treatment planning right now with these softwares, you cannot remove a tooth that's there. And so that's one of the things that we've been able to accomplish. So you do a digital subtraction of these teeth, and then that gives you the positioning to go ahead and add the crowns back in and develop your surgical guide with the appropriate sleeves. This is the radiographic case that we just showed, and you can see that we were able to place in a flapless manner in ideal positioning for screw-retained immediate provisional. So clearly the CBCT has made a positive impact on my personal clinical outcomes, and I think it's critical that you utilize it in your practices for these different applications. The visualization of anatomic structures, osseous topography for preoperative surgical case planning, and patient engagement is critical. We also are allowed to see hidden periodontal and perioendo defects. We've only touched upon some of the advantages of what we see on a day-to-day basis. Again, the sad thing is that very few offices have CBCT technology incorporated into their day-to-day routine. And so one of the things that you can do is you can utilize someone who does have a CT scanner. We open our office to others, and they send their patients over to us. We just take the CT scan. So I think it's something that's critical to include in your treatment planning. It allows us to tie your implant position treatment planning to the surgical guide. That is either with guided surgery or without. You can evaluate in 3 dimensions your clinical outcomes following your bone grafting. And then kind of the last, but probably the most important, is the ability to critically evaluate your implant surgery outcomes. What that means is that you and your own skill set, you've seen some outstanding clinicians today, and you'll continue to see that. But for me, I'm kind of your average surgeon in the office. I want to make sure that I know what works for me. What works for Danny Boozer may not work for us. What may work for Dennis Tarnow may not work for us. So you want to make sure that you know what works in your hands and that you've evaluated it so that you can make a decision for yourself what incision designs work for you, what bone graft materials work for you, and what kind of timelines will work for you so that you get the most successful outcomes. And with these low radiation CT scanners of reasonable cost, I think now we're at an era where we can really turn things into a 3-dimensional office rather than a 2-dimensional historic type perspective. Anyway, thank you very much for your attention.